Hello everyone, I am myself Dr. Rajesh Guba. I am the general medicine educator. So in this session, I will be discussing a very important topic in the connective tissue disorders, that is dermatomyositis and as well as the polymyositis. So these two conditions, that is dermatomyositis and as well as the polymyositis. Both of them, they are included in the idiopathic inflammatory myopathies. And let me discuss what exactly is the difference between the dermatomyositis and as well as the polymyositis. If you see the definition of the polymyositis, here you have the skeletal muscle weakness. Right, and there is no skin involvement in case of the polymyositis. Whereas in case of dermatomyositis, you will have both. There will be skeletal muscle weakness and along with that, you have a characteristic skin rash. Okay, so that is what is the difference between the polymyositis and as well as the dermatomyositis. Okay, the another important thing that you need to know is, although their clinical presentation and treatment are similar, the two diseases pathologically they are quite distinct. See, dermatomyositis, you have the skin findings and which is pathognomic of your dermatomyositis. But in case of the dermatomyositis, there is no muscle involvement. Okay. Now, if you see the age of incidence, dermatomyositis and polymyositis, they affect the persons of any age. But the peak incidence is in 5th and 6th decades of life. Okay. So, the peak incidence it is in 5th and as well as the 6th decades of life. And if you take the incidence between women and as well as men, women they are affected twice as commonly as men. Okay, so in women, right, in women the incidence it is almost twice compared to that of men, right? And in which group of individuals this is more common? It is more common in blacks rather than whites, right? It is more common in blacks rather than whites. Now, followed by that, let me discuss about polymyositis in detail. So, these particular patients, what is that we have discussed? You have the skeletal muscle weakness, right? So, I will discuss one by one. First, I will discuss polymyositis and then followed by that, the dermatomyositis. Okay, so there will be skeletal muscle weakness and along with that, there will be dermatological findings also in these patients with the polymyositis. And this polymyositis may be associated with other connective tissue diseases also, right? And what are the other, right? What are the other connective tissue diseases that you will see in association with the polymyositis or dermatomyositis? The associated connective tissue disorders include scleroderma, right? And second, it can be associated with, right? It can be associated with systemic lupus erythematosus and it can also be associated with MCTD, right? And what is MCTD? That is mixed connective tissue disease. and it can also be associated with Sjogren syndrome. Right, it can also be associated with Sjogren syndrome. That is what is the associated connective tissue disorders with polymyositis and as well as the dermatomyositis. And if you take this terminology called primary idiopathic polymyositis. So this primary idiopathic polymyositis, it is the condition of an autoimmune etiology. Please remember, this polymyositis, it is of, right, it is of the autoimmune etiology. That means the antibodies, they are formed against the skeletal muscles. So it is a condition of autoimmune etiology in which the skeletal muscle is damaged by non-suppurative inflammatory process. Okay, so here skeletal muscle it is damaged by non-suppurative inflammatory process, right? And that is the etiopathogenesis for the development of the polymyositis. And in order to have the inflammatory process to occur, right, in order to have the inflammatory process to occur, this polymyositis, it is dominated by lymphocytic infiltration. Right, it is dominated by lymphocytic infiltration. Please remember, that's an important point. And this polymyositis, right, this polymyositis, it is a subacute inflammatory myopathy. Right, it is a subacute inflammatory myopathy. So please remember, it is a condition of autoimmune etiology in which skeletal muscle is damaged by non-suppurative inflammatory process which is dominated by lymphocytic infiltration, and it is a subacute inflammatory myopathy and it mimics many other myopathies, right? And if you see the characteristic features, I said you these polymyositis, it has the muscle weakness, and what will be the pattern of that muscle weakness? It is the symmetrical weakness. Right, it is the symmetrical weakness of proximal limb muscles. Right, it is the symmetrical weakness of proximal limb muscles, especially, right, especially the muscles of the hips and the thigh, right, especially muscles of the hips and thigh, which is nothing but the pelvic girdle, right, which is nothing but the pelvic girdle. And after the involvement of the proximal muscles of the lower limb, then it is followed by, right, it is followed by the involvement of the shoulder girdle muscles. Right, followed by the involvement of the shoulder girdle muscles. So that will be the pattern of the muscle involvement. Initially the proximal muscles of the lower limb, followed by that the involvement of the proximal muscles of the upper limb. And these individuals, they also have weakness of flexor muscles of the neck. Right, there will be also weakness of flexor muscles of the neck. And because of the weakness of the flexor muscles of the neck, these individuals, they have head drop. Right? These individuals, they have head drop. That is, they have difficulty, right? They have difficulty in holding the head. Right? They have difficulty in holding the head up. That is what is the characteristic features of the muscle involvement in patients with the polymyositis. And if you take other characteristic features, let me tell you, in case of polymyositis, there is also involvement of the striated muscles of the pharynx. Right? Striated muscles of the pharynx. So, because of the involvement of the striated muscles of the pharynx, these individuals, they have difficulty in swallowing, and that particular difficulty in swallowing, we call it as dysphagia. Right, we call it as dysphagia. So there is involvement of the striated muscles of the pharynx wherein they have difficulty in swallowing, that is called dysphagia. And then followed by that, there is involvement of the respiratory muscles in the later part of the disease. Right, so there is involvement of there is involvement of respiratory muscles in the later part of the disease. And because of the involvement of the respiratory muscles, the individual will land up in the respiratory failure. And what type of respiratory failure is this? It is type 2 respiratory failure. Right? What type of respiratory failure is this? It is type 2 respiratory failure. And because of the development of type 2 respiratory failure, what will be the gaseous abnormalities that the individual will have? They will suffer with hypoxia and hypercapnia. Right? Decreased oxygen and increased carbon dioxide. That is what is your type 2 respiratory failure. And what about the deep tendon reflexes? The deep tendon reflexes, they are preserved. Right? The deep tendon reflexes are preserved. But when the involvement of the muscles, right, when there is severely atrophic muscles, in such case the deep tendon reflexes will be absent. Okay, so if there is severe atrophy of the muscles, in such case the deep tendon reflexes, they will be absent. That is what is the other characteristic features. So initially what I have discussed, proximal muscle weakness will be there, mainly in the lower limb, that is hip girdle and as well as thigh muscles. Followed by that, there is involvement of the weakness of the shoulder girdle. And the other muscles which are involved is the striated muscles of the pharynx, wherein the individual will have dysphagia. In very later part of the disease, there will be involvement of the respiratory muscles, making the individual to land up in type 2 respiratory failure, which is characterized by hypoxia and hypercapnia. And let me tell you, in early stages, the deep tendon reflexes are preserved. But when the muscles are severely atrophied, that is the point when the deep tendon reflexes, they are absent. Now, always remember its diagnosis, which one? The polymyositis diagnosis is essentially established as a diagnosis of exclusion. Right? It is always a diagnosis of exclusion. And this polymyositis should be considered in adults and rarely in children who do not have any of the following. See, patients with polymyositis, usually they do not have the involvement of the extraocular muscles. Right? There is no involvement of extraocular muscles and the facial muscles. right? There is no involvement of extraocular muscles and facial muscles. Please remember, that's an important point. And if there is involvement of extraocular muscles and as well as facial muscles, that will exclude the diagnosis of the polymyositis. That will exclude the diagnosis of polymyositis. And these ocular muscles are almost never affected, right? They are never affected. Which one? The ocular muscles, except in rare case associated with myasthenia gravis. And even facial muscles, they are not affected in polymyositis. Okay. And next important thing that these individuals should not have is family history of neuromuscular disease. Right? Family history of right? They should not have the family history of the neuromuscular disease, right? And next is they should not have any history of exposure to myotoxic drugs or toxins, right? They should not have any history of exposure to myotoxic drugs or toxins, right? This is another very important point. And they should not have any endocrinopathy, right? They should not have any endocrinopathy. That means they should not have thyrotoxicosis. They should not have any history of diabetes mellitus, because in thyrotoxicosis there can be proximal muscle weakness. In diabetes mellitus there can be proximal muscle weakness. And there should not be any neurogenic disease. Because certain neurological disorders, like you take the congenital muscular dystrophies, they have the weakness of the proximal muscles, so they should not have any neurogenic disease, right? And you take in case of radiculopathy, there will be proximal muscle weakness. That should not be there to consider as the polymyositis, right? And they should not have any history of muscular, right? They should not have any history of muscular dystrophy, right? Because even muscular dystrophies, they have the proximal muscle weakness, right? And they should not have any biochemical muscle disorder. Right? They should not have any biochemical muscle disorder, right? And lastly, they should not have rash, right? They should not have rash. So these features, whatever I have discussed, should not be there in polymyositis, right? And it is always the diagnosis of exclusion. And how do you treat these patients with polymyositis? The most commonly used medications to treat myositis include the steroids, that is corticosteroids. Right, that is corticosteroids. And in those individuals who have the adverse effects secondary to the steroid therapy, you need to use corticosteroid-sparing agents. Right, you need to use corticosteroid-sparing agents. And the two most common medications used for polymyositis, alternative to your steroids, will be azathioprine. Right, that will be azathioprine. And the other alternative medication is the other alternative medication is methotrexate. Right, we also have a monoclonal antibody that we give in the treatment of the polymyositis, that will be rituximab. So these are the most commonly used medications to treat polymyositis. The drug of choice will be corticosteroids. But in those individuals who have developed adverse effects related to corticosteroids, because corticosteroids, if they are being supplemented to the individual for longer duration, the individual may land up in the iatrogenic Cushing's. So in those individuals who are not able to tolerate these steroids, for them, you need to give azathioprine and as well as the methotrexate. And the other alternative medication will be the rituximab. Then, followed by that, the dermatomyositis. Right, followed by the dermatomyositis. So we have finished polymyositis. Let me discuss the dermatomyositis. Dermatomyositis is a distinctive entity identified by a characteristic rash. Okay, so the presence of a characteristic rash, it is a very important feature of the dermatomyositis, right? And this muscle weakness, it may or may not be there. If at all, if there is muscle weakness, usually it will be often a preceding muscle weakness. Right, usually it will be a preceding muscle weakness. That is what you will have in case of the dermatomyositis, right? So it is identified by a characteristic rash accompanying more often a preceding muscle weakness, but along with the rash you don't have the muscle weakness, right? Now, so if you see the characteristic rash in case of the dermatomyositis, this will be a heliotrope rash. Right, this will be a heliotrope rash, and in this heliotrope rash you have a characteristic blue purple discoloration of upper eyelids. Right, blue purple discoloration of the upper eyelids along with edema. Right, along with edema, that is what is your heliotrope rash. Then we have Gottron's patch. Right, now what is this Gottron's patch? Gottron's patch, it is erythema of the knuckles, right? So that means there will be redness of the knuckles. So this will be the characteristic skin manifestations in dermatomyositis. And what about the muscle weakness? Yes, muscle weakness, it can be a preceding muscle weakness before the appearance of the rash. Now, apart from that, we have many other dermatological manifestations. Let me discuss one by one. So the first, you see the heliotrope rash, right? Where all you have the rash here? In the periocular area. Right, you have the periocular rash, then there will be facial erythema, right, that is redness over the face, and there can be edema along with this particular rash. So there will be also facial edema. Right, there will be also facial edema. And this particular rash, what will be the color of this particular heliotrope rash? So it is pink or it is blue in color. Right, it is pink or blue in color, or it can be even purple color rash. And this discoloration is present in the periocular area as well as in the facial area. Then followed by that, the Gottron's papule. See, this Gottron's papules, we also call this as Gottron's sign. right? We also call this as the Gottron's sign. This particular Gottron's sign, it is a violaceous papules over the knuckles. So these are the knuckles. Violaceous papules over the knuckle, right? And not only that, either violaceous, that is, you also have the presence of erythema of the knuckles with raised violaceous scaly eruptions. Right, so you have the presence of the scaly eruptions. That is what is your Gottron's papules or the Gottron's sign, which are nothing but the violaceous papules over the knuckles. Then we have what is called the V sign. V sign, it is an erythematous rash over other body surfaces such as the anterior chest. So you can see that here, this is your anterior chest. So apart from your face and apart from the knuckles, you also have the erythematous rash, right? You also have the erythematous rash over other body surfaces such as the anterior chest, right? And what is the shape of it? It is V form, right? It is V form or it is called V sign. Then we have, yes, you take this V form or V sign, you have a differential diagnosis of this, and that is nothing but the necklace sign in pellagra, right? And this is called Kajal's necklace, right? So where do you see that? You will see that in case of niacin deficiency, right? You will come across this in niacin deficiency. That is the differential diagnosis of the V sign, what you come across in dermatomyositis. Then followed by that, we have what is called the shawl sign. Shawl sign, it is an erythematous rash over other body surfaces. Right, it is an erythematous rash over the other body surfaces, right? Where all you can have this erythematous rash, this can be seen over the upper trunk, this can be seen over the neck, this can be seen over the back, and as well as the shoulders. Right, that is what is your shawl sign. So where all you have this erythematous rash that is present over the upper trunk, neck, back and shoulders, that is what is your shawl sign. Next, followed by that, periungual telangiectasias. Periungual telangiectasias, you know, they are dilated capillary loops at the base of the fingernails. Right, dilated capillary loops at the base of fingernails. That is what is your periungual telangiectasia, which are nothing but dilated capillary loops at the base of the fingernails. This is another characteristic dermatological finding in patients with the dermatomyositis. And you have a characteristic hand that is called as the mechanic's hand. So here, if you take the skin of these individuals, the skin, it is irregular, it is thickened, right? Irregular, thickened, and the skin, it has distorted cuticles, right? The skin, it has distorted cuticles with rough and cracked areas over the lateral and palmar areas of the fingers. Okay, so this particular skin, it is rough in texture and it has the cracked areas, right? It has the cracked areas. And where all you will observe these particular dermatological manifestation, that is over the palmar areas of the fingers. Right, that is over palmar areas of the fingers, right? Next to this mechanic's hand, the another important dermatological manifestation is calcinosis cutis. Calcinosis cutis, it is the presence of the hard calcium deposits, right? The presence of hard calcium deposits in the skin, right? That is what is your calcinosis cutis, right? So these are all the dermatological manifestations that you will see in patients with the dermatomyositis. So heliotrope rash, Gottron's papule, V sign, shawl sign, periangual telangiectasia, mechanic's hand, and then calcinosis cutis. Now, you need to know the malignancies which are associated with the dermatomyositis. Let me tell you, there is increased risk of malignancy in adult patients with dermatomyositis. Okay, so there is increased risk of there is increased risk of malignancy in adult patients with dermatomyositis. Indeed, up to 1 patient in 4 with dermatomyositis has an occult malignancy. So 1 in 4, right? 1 in 4 patients with dermatomyositis, they have an occult malignancy. So what do you mean by this word occult malignancy? Occult malignancy means, occult means hidden. That is what is called occult malignancy. And the malignancies most commonly associated with dermatomyositis, they include the ovarian carcinoma, then carcinoma of the lung, carcinoma of the pancreas, carcinoma of the stomach, next colorectal cancer, and non-Hodgkin's lymphoma. So these are the malignancies that are most commonly associated with the dermatomyositis, right? The most common one will be ovarian malignancy and the least common one will be non-Hodgkin's lymphoma. Even that can also be asked as a multiple choice question. Now, you need to know a very important syndrome that is called as anti-synthetase syndrome. See, a subset of patients with polymyositis and dermatomyositis, they develop this anti-synthetase syndrome, right? They develop this anti-synthetase syndrome. Now, what is this anti-synthetase syndrome? It is the disorder where a group of findings including inflammatory non-erosive arthritis. So, in these individuals, along with the dermatomyositis, there will be inflammatory non-erosive arthritis. Right, inflammatory non-erosive arthritis. Along with that, they have the presence of fever. They have Raynaud's phenomenon. See, in case of this Raynaud's phenomenon, these individuals' hands or extremities, whenever they are exposed to cold, they develop severe cyanosis. That is what is your Raynaud's phenomenon, right? So a subset of patients with polymyositis and dermatomyositis, they develop this anti-synthetase syndrome, right? And what is this? What are the findings in anti-synthetase syndrome? That includes inflammatory non-erosive arthritis, fever, Raynaud's phenomenon. They will also have the development of mechanic's hand, right? And what is this mechanic's hand? It is hyperkeratosis along with radial and palmar aspect of the fingers that I have already shown. And in this anti-synthetase syndrome, right, there will be also development of interstitial lung disease, right? There will be also development of interstitial lung disease and often severe muscle disease associated with certain autoantibodies, right? So there will be also severe muscle disease associated with certain autoantibodies, right? And what will be that autoantibodies? These autoantibodies include anti-Jo1 antibodies, right? These antibodies include anti-Jo1 antibodies. That is what is your anti-synthetase syndrome, right? So it is a subset of patients with polymyositis. Not all the patients, a subset of patients with polymyositis and dermatomyositis, they develop this anti-synthetase syndrome, and these are the features of the anti-synthetase syndrome. Now, after having discussed about polymyositis and dermatomyositis, now let me tell you the differences between this polymyositis and dermatomyositis. Polymyositis, let me tell you, the age of incidence is more than 18 years. Dermatomyositis, that is seen in adulthood and even childhood, but preferably or most commonly in adults. Familial associations are absent in both of them, right? Familial associations are absent in both of them. And what about extramuscular manifestations? Yes, extramuscular manifestations, they are present in both. And then the associated conditions. So if you take the connective tissue diseases, yes, there will be associated connective tissue diseases with the polymyositis, and that can be your SLE, scleroderma and all. And even there can be associated connective tissue diseases even with dermatomyositis as well. And what will be that connective tissue diseases associated with dermatomyositis? That includes scleroderma, mixed connective tissue disease, that is called overlap syndrome, right? And what about autoimmune diseases? Autoimmune diseases, in case of polymyositis, they are very frequent, right? Autoimmune diseases, they are very frequent in case of polymyositis, whereas in dermatomyositis, it is infrequent, right? It is infrequent in case of the dermatomyositis. And what about the malignancies? You don't have any associated right? You don't have any associated malignancy in case of polymyositis, whereas in case of dermatomyositis, yes, you have the associated malignancy. And what about the viral infections? Yes, you have the associated viral infections in polymyositis, but absent in case of the dermatomyositis. And what about the drugs? Yes, both of them, they can have association with drug intake causing the polymyositis or the dermatomyositis. And what about the parasites and bacteria? Yes, in case of polymyositis, but absent in case of the dermatomyositis, right? Now, after that, you need to know what is the pathogenic mechanisms in between these two. In polymyositis, it is T-cell infiltration, whereas dermatomyositis, it is the immune complex formation. Right, it is the immune complex formation. And what about skin rash or dermatitis? In case of polymyositis, there is no skin rash or dermatitis, but whereas in dermatomyositis, you have the presence of the skin rash or dermatitis. And what about pharyngeal involvement? Pharyngeal involvement is present in both, and because of the pharyngeal involvement, these individuals, they'll have difficulty in swallowing, and that we call it as dysphagia. And what about proximal muscle involvement? Yes, proximal muscle involvement, it will be there in both, right? Proximal muscle involvement will be there in both. And what about ocular muscle involvement? Ocular muscle involvement, it is absent in both, right? There is no ocular muscle involvement at all. And what about facial muscle involvement? Even facial muscle involvement is not there, right? Even facial muscle involvement will not be there in case of your polymyositis and as well as the dermatomyositis, right? So these are the very important differences between the polymyositis and as well as the dermatomyositis. Now you take the myositis specific antibodies. So I said you like the autoantibodies are being present in case of this myositis. Myositis specific antibodies, they are the autoantibodies, right? They are the autoantibodies, and these autoantibodies, they are usually directed against intracellular ribonucleoproteins, right? They are usually directed against intracellular ribonucleoproteins, right? They are directed against intracellular ribonucleoproteins that are involved in protein translation. These ribonucleoproteins, they are involved in they are involved in the protein translation. So that is about your myositis specific antibodies. Now, what are those autoantibodies? The three best described myositis specific antibodies, they include number one, anti-Jo1, right? And this anti-Jo1, it is directed against RNA histidyl synthetase. And then we have another important antibody, that is anti-Mi2, right? Anti-Mi2. Then we have anti-SRP, right? So these are the three best described myositis specific antibodies, right? And what does this SRP stands for? It is an anti-signal recognition particle, right? Anti-signal recognition particle. And if you take the sensitivity of these antibodies, right, the sensitivity of these antibodies is low, right? The sensitivity of these antibodies is believed to be low. So these are the three best described myositis specific antibodies. Now let me discuss the involvement of these antibodies and their association and clinical features. So you take this anti-Jo1 antibodies. Anti-Jo1 antibodies, they are seen in case of polymyositis. And sensitivity, if you see, 30% is the sensitivity. And the clinical features is that they are acute in onset, right? Acute in onset. And this anti-Jo1 antibodies, if it is being present, it predicts the deforming arthritis. Right? It predicts the deforming arthritis. And there is also development of the Raynaud's phenomenon and pulmonary fibrosis. Right, pulmonary fibrosis. So that will be the clinical feature, right? Acute in onset, predicts the deforming arthritis, Raynaud's phenomenon and pulmonary fibrosis. And how will be the prognosis of these patients with anti-Jo1 associated antibodies? The prognosis is moderate, right? Prognosis is moderate. So moderate respond to therapy but persistent disease. That is what is your anti-Jo1 associated polymyositis. These antibodies, anti-Jo1 sensitivity is just only 30%, right? So next, coming to your anti-Mi2. See, anti-Mi2, it is present in case of dermatomyositis, right? Associated with dermatomyositis. And what about the sensitivity of this anti-Mi2? Sensitivity is just only 5%. And even this anti-Mi2 associated, right, even this anti-Mi2 associated disorder, it is relatively acute in onset, right? It is relatively acute in onset, and you have the characteristic dermatomyositis rash, that is, you have the presence of, right, you have the presence of the V sign, right, and you also have the presence of the shawl sign, and there is also cuticular overgrowth, right? There is cuticular overgrowth. And how will be the prognosis of this anti-Mi2 associated disorder? The overall prognosis, it is good, and they have a very good response to therapy, right? They have a very good response to therapy and they have a very good prognosis overall. Then followed by that, you take the anti-SRP associated disorder. Anti-SRP associated disorder, that includes polymyositis or dermatomyositis associated disorder. Right, polymyositis or dermatomyositis associated disorder, and the sensitivity is less than 5% sensitive. And if you take the clinical features, even this anti-SRP, it is acute in onset, and if anti-SRP is present, let me tell you, it represents severe weakness, right? It represents severe weakness. And how is the prognosis of anti-SRP associated polymyositis or dermatomyositis? It has a poor prognosis, right? And there is a poor response to therapy. Okay, so out of these three, anti-Jo1, anti-Mi2 and anti-SRP, the one which is having a good prognosis is your anti-Mi2. Even anti-Jo1, moderate prognosis. Anti-SRP, even it is associated with the poor prognosis. Then coming to the treatment of this dermatomyositis, prednisolone is the first line treatment of choice for polymyositis. Right, prednisolone, it is the first line treatment. Right, it is the first line treatment of choice for polymyositis. Right, and what should be the daily dose of this prednisolone? The daily dose of prednisolone, it is around, right, it is around 40 to 60 milligrams or more. And this oral formulation, right, oral prednisolone, it is required initially, right, it is required initially. The dose is then adjusted downward while monitoring the muscle strength, right? If the muscle strength is improving, then the dose is slowly reduced. And so the dose, right, the dose, it is adjusted while monitoring the muscle strength right, while monitoring the muscle strength and as well as the serum levels of the muscle enzymes. Right, serum levels of the muscle enzymes. That is about the dose how you need to taper. And long-term use of corticosteroid is often needed and the disease may reoccur when they are completely withdrawn. Okay, so long-term use, right, long-term use is often needed and the disease may reoccur when they are completely withdrawn. And next to the corticosteroids, we have the immunosuppressants. So if you take the other immunosuppressants, see for example, if the individual is not able to tolerate the corticosteroids, then you need to have an alternative immunosuppressants. The immunosuppressive agents are indicated in patients who do not improve with steroids and who are not tolerating with the steroids. Okay, so indication is no improvement with steroids. Then you need to add this immunosuppressive therapy. This no improvement should be within a reasonable period. That means you have given steroids. You have given steroids for nearly around 4 weeks. Up to 4 weeks you have given, but still there is no response. That is the point when you need to give this immunosuppressive therapy. And what will be that alternative agent? This alternative agent is methotrexate, right? Methotrexate, please remember, it is an antifolate agent, right? It is an antifolate agent. Whenever you are giving this methotrexate, you need to supplement the folinic acid, right? And the important adverse effect of methotrexate is it will cause bone marrow suppression, right? And it will also cause it will also cause the pulmonary fibrosis. That is what is the adverse effect of the methotrexate. Okay. Next, the other important point you need to know the other alternative immunosuppressants next to your methotrexate. That includes azathioprine. Next, cyclophosphamide, chlorambucil, and then cyclosporin. So these are the immunosuppressants that you need to give if the individual is having no response with steroids. And apart from that, the other agents include intravenous immunoglobulins, right? Intravenous immunoglobulins. These intravenous immunoglobulins has been used for the short-term treatment of steroid-resistant cases. Okay. Right, short-term treatment of steroid-resistant cases of polymyositis, you need to give this intravenous immunoglobulin, right? And we have few more agents that includes mycophenolate, right? Apart from this IVIG, right? Apart from this IVIG, we also have mycophenolate mofetil. Mycophenolate mofetil, the dosage around 1 to 1.5 grams, right? Around 1 to 1.5 grams. This is given orally twice daily. And this mycophenolate mofetil, this may be useful as a steroid-sparing agent. right? This may be useful as a steroid-sparing agent. And next to this mycophenolate mofetil, we have rituximab. Rituximab is effective in some patients with inflammatory myositis unresponsive to prednisolone, right? Given to patients with inflammatory myositis. Right? Inflammatory myositis unresponsive to prednisolone. Okay, that is about the rituximab. And this particular rash of dermatomyositis, it is often photosensitive. So patients should limit the sun exposure. Very, very important. Okay. So limited limited sun exposure. And the skin manifestation, whatever have been developed, for that you can also give hydroxychloroquine. And what is the dosage of hydroxychloroquine? That is around 200 to 400 milligrams per day. Right, 200 to 400 milligrams per day. But it should not exceed 5 milligram per kg. Right, it should not exceed 5 milligram per kg. Even this will reduce the skin disease. And what should be the diet? So, if you see the diet and as well as activity in case of this polymyositis, patients with polymyositis may benefit from the high protein diet because there is severe muscle weakness, and muscle is the one which is made up of a protein, right? So, high protein diet will benefit these patients with the polymyositis. Okay, so that completes the discussion of the polymyositis and as well as the dermatomyositis. Okay, so dermatomyositis, you have skin manifestations and muscle weakness, whereas polymyositis, only muscle involvement, no skin involvement. So you see the question, which of the following is not true about polymyositis? Limb girdle weakness, ophthalmoplegia, paraneoplastic syndrome, spontaneous discharge in electromyography. Let me tell you, in both of them, either polymyositis or dermatomyositis, there is no ocular involvement. Ophthalmoplegia will not be there. And in these patients with the polymyositis, there will be symmetrical proximal muscle weakness and mainly of the lower limb, and then followed by that the shoulder girdle, that is upper limb muscle weakness will be there. And ocular muscles are never involved in the generalized polymyositis. Okay. Next, yes, it is associated with certain malignancies. It is associated with paraneoplastic syndrome, and there will be spontaneous discharge in the electromyography. Right? And in these patients with polymyositis, you don't have any rash. You don't have any rash. Okay? Rash involvement is not the feature of your polymyositis, and there is no family history of neuromuscular disease, and there is no history of exposure to myotoxic drugs. There is no endocrinopathy. There is no biochemical muscle disorder as well. Okay? So that is about, and you need to know about the myotoxicity. Right? There are certain drugs which will cause myotoxicity, and that is not there in case of your development of polymyositis. So what are those drugs which will cause direct myotoxicity? The examples include alcohol, then cocaine, glucocorticoids, lipid lowering drugs, anti-malarials, then we have colchicine, right? Then we have colchicine. Next, zidovudine. Right? This colchicine, it is associated with vacuolar myopathies. right, associated with vacuolar myopathies, whereas zidovudin, it causes mitochondrial myopathy. Right, it is associated with mitochondrial myopathy. Which one? The zidovudin. Okay, whereas even these alcohol, cocaine, glucocorticoids, lipid lowering drugs. What are those lipid lowering drugs? That includes the statins. These, they are associated with vacuolar myopathies. Right? So that is about that. These drugs, they cause direct myotoxicity. Right? So these are some of the very, very important points on the topic of dermatomyositis and polymyositis. Thank you very much.